We're going to be using ketamine for several different indications this year, so I wanted to do a refresher on ketamine. That's what this brief lecture is going to be about. So what is ketamine? It's classified as a general anesthetic agent. It's actually a dissociative anesthetic, short-acting. It's actually related to PCP, which is angel dust. Came out in about 1970s. Tremendously safe drug, although you may see in some of the hospitals they're getting a little more comfortable with it now, but traditionally they're less comfortable with this medication because it's a medicine that's typically been used in the operating room. So what does it do exactly? So ketamine can give you profound analgesia, sedation, amnesia, anesthesia, immobility. It really has remarkable properties. In fact, in the military they even use this for seizure control. So it can do lots of things, puts people to sleep, makes them forget, and removes their pain. So how does it do this, and what are its characteristics? One of the reasons why ketamine is so safe is because you don't lose your airway with ketamine. You maintain your pharyngeal and laryngeal reflexes, your cardiovascular and respiratory systems stay either the same or they actually get a little bit better in terms of they get stimulated. You might actually get a little rise in blood pressure. You don't get respiratory depression like you do with other sedatives. And one of the other properties ketamine has is that it's actually a potent bronchodilator. So it's kind of like giving a sedative plus albuterol to somebody because it will dilate the airways. So it's a really good choice in folks with severe asthma that need to be intubated. So the pharmacokinetics, after you give an IM shot, it's rapidly absorbed. So let's say you've got an excited delirium person, you're going to be giving them an IM shot. You can expect somewhere between 2 and 4 minutes they're going to go out. They're going to be out of it, which is great. And then you've got maybe 15 to 30 minutes, depending on the size of the patient, that they'll be out about that time. So it's enough time to get them on the stretcher in a good position, put some soft restraints on them, get IVs, and start resuscitating them. The ketamine is rapidly distributed throughout the body and is excreted by the kidneys, so it may be a little longer half-life in those folks with renal failure. Now, we are going to be giving ketamine intravenously this year as well to IM. So the IM we're going to be using for our excited delirium / violent folks. IV we're going to use for different indications. So, and we're going to go into that in a little bit. But IV, what you'll see is an even faster onset of action. Within 30 seconds of giving it, you're going to see the effects of ketamine. Its half-life is a little bit shorter, about 10 minutes. Its duration of action is a little shorter when you give it IV because it's metabolized faster. So here are the indications. This is what we're going to be using ketamine for this year. Obviously, we're using it for our violent, agitated patients and our excited delirium. That's what we've been using it for in the past. But now we're also going to be using it intravenously for procedural sedation and also for pain control. Here are the dosages. Our dose for the violent patient / excited delirium, that's intramuscular, stays the same, 400 milligrams for those folks. If you really want to do it per kilo weight, if you've got somebody really small, it's 4 milligrams per kilo, but I recommend just give it. You can't really overdose these patients. It's got a really wide safety margin. So for most of the time, really just draw up 400 milligrams, give them a single shot. But I'm going to caution you that when you give an intramuscular shot, it's got to be intramuscular. If you've got somebody you're fighting with and all you can do is hit them in the buttocks and it's all fatty there, it's not going to work really well because it's not absorbed real well from the fat. You've got to get them in the side of the thigh, in the muscle portion. That's when you know you're going to get some reliable effects. And then you'll see, I've got in yellow here, the IV/IO doses are a little bit different. And it's critical that you remember that if we're going to give it intravenously or by IO, you must dilute the ketamine. And the reason for that is because when you give intravenous or intraosseous ketamine and you give it really fast, it can cause some laryngospasm. So we want to dilute that out. That makes it less likely we're going to get into any laryngospasm problems. So for sedation, say for intubation, for example, or other procedural stuff, 200 milligrams. For pain control, 25 milligrams. And when you get to pain control, it's a good choice in people who have relatively low blood pressure. So for your trauma folks, absent penetrating eye trauma, because that's a contraindication. But if you've got a trauma patient, blood pressure's hanging around 80, 90 systolic, and you're a little nervous about giving fentanyl, fine. You can use ketamine first line. Or you can use ketamine with fentanyl. And you can give 25 milligrams of ketamine, diluted out in a syringe, and we're going to go over the procedure, how you dilute that. You can give it up to 3 times. So you can get a total max dose of 75 milligrams. So give it a little bit of time, 5 minutes in between each dose to see if you get the desired effect. And if you need to give a little bit more, you can repeat this. So you'll see that in the protocol that you've got repeats on that. So adverse reactions. In general, ketamine is really well tolerated, but these are some of the things you can expect to see once you give it. You might see the blood pressure rise, might actually get a little hypertension, might get some tachycardia. That's self-limited, do nothing about it, it'll go away. On occasion, you'll get laryngospasm, particularly if you give it IV and you've forgotten to dilute it. So don't forget to dilute it. If you get some laryngospasm, it's often self-limited. Sometimes just some oxygen, high-flow oxygen. Sometimes bag valve mask will make it go away. Rarely will you have to do anything more than that. You might see some hypersalivation. That doesn't happen often, but you can use atropine for that. You can get some nausea and vomiting, but typically the nausea and vomiting occurs when people are waking up from the ketamine. So as you get somebody waking up for it, you'll see we can talk a little bit about Versed. You might get some muscle movements that look a little seizure-like, tonic-clonic. It's not a seizure. You just get some little muscle movements. They're harmless. You don't need to do anything about it. Rarely, you might get some transient respiratory depression. And often this is not due to ketamine, but it's a combination of ketamine plus whatever other junk is in their system. So when you start adding a bunch of medications together, like say they're already abusing alcohol and a bunch of other drugs, barbiturates or whatever, and you add ketamine on top of that, then you might see some respiratory depression. So when you've got people that you're going to be giving it to who have polypharmacy overdoses, be wary of the airway, because in certain circumstances it could affect the airway. But ketamine alone by itself is not going to give you a lot of respiratory depression. And one of the things you'll know that the medicine's kicking in is you'll see the eyes start shaking back and forth. You get this really pronounced nystagmus. That's how you know that they're really getting sedated with the ketamine. So some more adverse reactions. You might get some psychological adverse reactions. Again, this is when they're waking up. It's more common in adults as opposed to children. And they get these sort of bad trips, so to speak. The sort of visual hallucinations, nightmares they get. It's called an emergence reaction. Versed can actually blunt that. But you don't want to give Versed while they're really sedated with ketamine. You're only going to do the Versed if the patient starts to wake up, which most of the time the patient's not going to wake up with us. We'll be at the hospital before they start to wake up. But if you have a prolonged transport and the patient's starting to wake up and they're starting to get nauseous or starting to have these visual hallucinations, that's the indication for Versed. The Versed is not to keep them down. It's not for further sedation. That's not the purpose. It is given in a low dose to try to prevent some of these adverse reactions. So contraindications, obviously if you're allergic to ketamine, penetrating globe trauma, pregnancy, it's not known the effects on pregnancy. It's not rated one way or the other. So since it's unknown, we're just going to avoid it in pregnant patients. And you don't want to use it for non-traumatic chest pain. The reason is the same reason why you can raise the blood pressure and raise the heart rate is why you don't want to give it in ischemic chest pain, is because it can have an epinephrine-like effect where it can really stimulate the body, and that's why it makes the pressure go up. And that could increase the work on the heart, theoretically. So you don't want to use it for possible cardiac cases. So not for non-traumatic chest pain. Stay away from that. So here's our procedure for excited delirium. You get these folks under control. You give them the IM shot. Understand that these people are in a pre-cardiac arrest state if you're using it for the excited delirium cases. They typically have they're febrile, they've got a lot of metabolic acidosis going on board. So give them the ketamine, allow them to hyperventilate. That's a huge thing. They have to be able to compensate by hyperventilating. No holding them down. Don't put them prone. They got to be supine. Put the soft restraints on them. Get an IV in them. Start cooling them down with cold saline or at least cold packs if you don't have the cold saline. Versed, again, only if they start to wake up. Be quick with giving bicarb for true excited delirium. Not just the alcoholics that are violent, but if you have a true, bizarre, excited delirium case, which you usually tell because they're taking their clothes off and they're acting all sort of bizarre behavior, they're violent, they don't feel pain, etc. These folks, they have a lot of acidosis, so be quick with giving them bicarb. And make sure, a lot of these cases, the police get involved, make sure these people go to the hospital. This is a true medical emergency. If the patient goes into cardiac arrest, if the excited delirium case, that is, goes into cardiac arrest, this is a scenario where bicarb is first-line drug. Normally, we don't use bicarb in cardiac arrest, but this is one of the exceptions to the rule. It's because they go into arrest because of severe metabolic acidosis. Hyperventilation, again, very important for these folks because the whole reason for the arrest is this severe acidosis. You need to blow off acid in these people. Aggressive IV saline infusion for the same reasons. Now, these are some of the liabilities we get into. Do not hogtie these folks. Do not compress the head or neck with your knee or foot. I mean, sometimes I know they're violent and they're hard to get control over them, and a lot of times they get a bunch of people pile on top. Don't do that. You have to allow these people to be in an upright position and allow them to hyperventilate, because if you suppress their hyperventilation by either putting them face down or putting their knee in the back, that's when the acidosis is going to get worse and they're going to go into arrest. So, in conclusion, ketamine, Safe drug, rapid acting. You can give it intramuscular for sedation of the violent and excited delirium patients. You can give it IV for sedation or pain control, IO as well for sedation or pain control. If you give it by the IV or IO routes, you're going to be diluting it. If you're going to give it IM, make sure you don't hit them in the buttocks. Make sure you hit them in the big muscle of the thigh, on the lateral thigh. Excited delirium patients, expect them to be hyperthermic, severe metabolic acidosis, psychosis, and consider these people to be pre-cardiac arrest. Allow them to hyperventilate. And Versed, we're going to use it only if the patient starts to wake up. Thanks a lot.